Hello, everyone, and welcome to this evening's hotly anticipated, pun intended, Ask the Expert session on menopause. It's more than a hot flush, and boy, is it ever. Before we continue, on behalf of Breast Cancer Network Australia, or otherwise known as BCNA, who are hosting this event, I would like to acknowledge the traditional owners of the land on which I'm presenting today, the Wurundjeri Woi-wurrung people, and pay my respects to their elders past, present, and emerging. My name is Navina, and I'm a consumer representative with BCNA. I have lived experience of breast cancer, having been diagnosed with triple negative stage 3 breast cancer in 2014, for which I underwent treatment in 2015. This webcast is an Ask the Expert format, and our expert for this evening is Dr. Tonia Mezzini, otherwise known as the Vagina Whisperer, from the Advanced Gynecological Surgery Center in Adelaide. I will hand over now to Tonia to introduce herself.
Thanks, Navina, and thank you for that lovely introduction. For those of you who don't know what a sexual health physician is, it's a bit like a gynecologist who doesn't operate, but I also have expertise around endocrinology and hormones, urology, and psychology, and I recently completed a Master's of Psychiatry through Melbourne Uni. So I often say to people, if your problem is up here and it connects to you downstairs, then I'm your girl. Or these days, I would say probably more woman, girl might be pushing it a bit. I will warn you in advance of my frankness, but I won't apologise for it. It's an occupational hazard, but it's really important that we can have these conversations in an open and a direct way, because shame and embarrassment has no place when we're looking for solutions. So yes, menopause is more than just a hot flush. And when Navina and I met the other night to talk about the presentation today, we were discussing the notion that actually maybe we should go back to that old-fashioned, perhaps slightly euphemistic title of the change of life, because menopause is not just the cessation of periods. It really does represent a huge watershed in a woman's life, and whether that be brought about by breast cancer treatment or biologically occurring, it is a big change. So we're going to talk a little bit about what menopause is. What is this thing called menopause? So it's changes to the menstrual cycle, symptoms of hot flushes, night sweats, difficulty sleeping, joint pains, fatigue. Genitourinary syndrome of the menopause is what GUSM stands for. We don't just call it atrophic vaginitis, because that just then refers to the vagina. It doesn't also refer to the pelvic floor and the urethra that are also implicated in estrogen deficiency symptoms. Osteoporosis, so thinning of the bones, cardiovascular disease, cognitive changes, the brain fog, you can't remember why you walked into a room kind of scenario, can't remember names, anxiety and mood changes, and then, of course, low libido, which is often tied in with sleep disturbance as well. So there's some of the symptoms. What I'm often asked about is the diagnosis of the menopause, and I jokingly, not really jokingly, say, we can put a man on the moon, but I can't tell you when you're going to go through menopause naturally. There are some blood tests, so an egg timer test or an anti-Müllerian hormone test. A pelvic ultrasound might show us how many oocytes or eggs you've got left in your ovaries. But even if you've got oligofollicular ovaries, the best we can say with that is that your last period will be sometime in the next 5 to 7 years. Your family history is important, and Navina and I were talking about, it's not an old wives' tale that your mother's age of menopause is roughly predictive for your own. So your mum's age of menopause does give you an idea of when you might go through menopause. If you're a late starter with your periods, you tend to be an early finish. If you're an early starter with periods, you tend to be a late finisher. So some women just seem to have very protracted menstrual lives. The strict definition of menopause is no period. So amenorrhea means 12 months of no period with a follicle stimulating hormone level in the menopausal range, so above 30 on at least 2 occasions, at least 4 to 6 weeks apart. And that means, and you can't do any hormone tests if you're taking the pill or you're on any cycle control or contraception, because then we're just testing the tablets that you're taking. Premature ovarian insufficiency, we would say that it's the absence of cycles and an FSH of over 25. And so that applies to women who are younger, so below 45. Navina, do you have any questions you want to ask before I keep rattling on? No?
I do. And what I thought I'd actually also do, Tonia, is let the attendees know that we've had about 150 questions from people who registered for this event. And because we only have an hour available, we've designed the webcast to answer as many of their questions as possible. And that we're going to start off with a bit of a wide-ranging group of questions and then follow up with more specific questions from the attendees. And having said all of that, please consider tonight's information as general advice only. For more specific information about your condition, please refer to your healthcare team or professionals in your healthcare professionals in your life. And one other thing I wanted to note is for the attendees, there's a live Q&A button in the question tab where you can submit your questions during the session. If you'd like to take some notes during the session, you can do so via the My Session Notes section. But don't forget to export your notes by clicking the export icon located on the top right corner of the page. There's a discussion forum where you can chat with the other attendees during the event. But just remember that everybody can see your comments. You'll also find an evaluation survey link and other resources under the handouts section. And if you have any technical issues, please comment in the chat and the admin support will be able to assist. Now, Tonia, I do have a few questions for you. So what happens to us when estrogen is withdrawn, either naturally or because, you're undergoing cancer treatment? And is there anything we can do about it?
Absolutely. So estrogen withdrawal affects the whole body as well as the pelvis and the genitals. And what we're going to do in this next section is try and address some of those questions. So just to the attendees, what we did was Ricky, who's one of the fabulous BCNA staff here, collated all of your questions that were submitted beforehand, and we incorporated them into the talk and into the slides. So hopefully we have actually covered off on everything. In particular, we wanted to talk about how you manage the side effects of hormone blocking treatment. So many women with an estrogen or progesterone receptor positive breast cancer, or even those women who don't have a hormone receptor positive breast cancer, will have estrogen and progesterone blocked, because we know that that can be the two of the hormones or chemicals that can drive the development of cancer. And you probably already know that there are different classes of adjuvant hormone therapy treatments. So tamoxifen is a SERM. Aromatase inhibitors include drugs like letrozole. And then there are GnRH agonists, which switch off ovulation at the level of the brain, and that's called Zoladex. The side effects of the hormonal blockade causes you to go into menopause. So there's no estrogen floating around in your system at all. And then there, of course, are the side effects of the individual medications. And we can't address in this seminar the side effects of tamoxifen versus an aromatase inhibitor. But Michelle White did do a webinar that's on the BCNA list that you could also have a look at if you wanted to address those concerns a little bit more. The choice of your medication is very much driven by your individual cancer profile, your age, and other variables. And so it is something that does need to be discussed one-on-one with someone who's on your treating team. But I would encourage you to exercise your right to obtain a second opinion if you feel that you haven't had sufficient explanation or you want to double check information. That's a reasonable fact-finding exercise to do. For some women, the benefits of adjuvant hormone therapy are low, so in the order of a couple of percent, but it's very subjective who decides what that couple of percent. So for some people, a 2 or 3% improvement in survival is enough for them to want to take a medication. For other women, 2 or 3% is not sufficient. And so it's broadly a diverse experience. So it's a question for women to make up their mind themselves. So in terms of estrogen deficiency symptoms, the big hitters are the hot flushes and night sweats. So these are the we call them vasomotor because it's your blood vessels as well as your whole body that's responding. That can lead into sleep disturbance, so you don't sleep through the night because of the hot flushes, but also sleep disturbance even in the absence of hot flushes. So a lot of women report that their sleep during the menopause transition is quite light. They're easily woken, and the sound of their partners blissfully snoring next to them is enough to make them want to suffocate them quietly. You're not alone. Women can also experience joint pains and fatigue, atrophic vaginitis or genitourinary syndrome of the menopause, and anxiety and mood changes. And the reason for that is that estrogen is a really potent neuromodulator. When we think about the chemicals that help our brain to work, we think about serotonin, adrenaline, noradrenaline, estrogen and testosterone are also really important chemicals in those pathways of good mental well-being and functioning. So the reason why you get hot flushes is that estrogen stops your thermoregulatory center, or basically your thermostat, from being able to control itself. And it's controlled by other neurotransmitters you might have heard of, like serotonin. And part of the reason why we use medications like SSRIs, which stands for selective serotonin reuptake inhibitors, try saying that 3 times fast, is because we are harnessing a known side effect of this medication. And so SNRIs will produce a 50 to 60% reduction in hot flushes. Now, that's not 100%, it's not 90%, but it is a reduction, and it's about the same reduction as if you were taking a 0.5 milligram of estrogen. Estrogen is absolutely, hands down, the best medication for hot flushes, but if you can't take estrogen, knowing what your other options are so that you can reduce the intensity and frequency is what we're getting at. And we know that these medications are equally effective in women who've got breast cancer, whether or not they're taking tamoxifen or an aromatase inhibitor, and whether or not they've had a medical or a surgical menopause. So quite often we will use low-dose SSRIs in women who don't have breast cancer because they may not choose to use estrogen, or we use them in combination. So we use doses at a very different dose range to what we do if we're prescribing for depression or anxiety, because there's a dose response curve that relates to the pharmacokinetics of a drug, so how they work in real life, that is quite different at lower dose ranges. And a lot of drugs we use for reasons that they weren't originally designed for. So amitriptyline, for example, which is commonly used as an antidepressant, in low doses works very well for pain, and we'll talk about that, because it was actually originally designed as a pain relieving medication, as local anesthetic. Viagra is another one. Viagra wasn't actually designed for erectile dysfunction. It was designed for pulmonary hypertension. It was just an accident that they found out it worked in that way. You can imagine the poor lab rats when they discovered that. Venlafaxine is an SNRI, so we use that at a dose of 37 to 75 milligrams. If you're using a treatment dose for depression, you'd be using 150 milligrams, for example. And sometimes, you'll consider starting a medication like venlafaxine if there's a bit of anxiety and some hot flushes, because you know that you've got that option to increase the dose. But if the dose goes too high, then you get the side effect on the other side, which is hot flushes. So if you've got someone on, say, 300 milligrams of venlafaxine as a treatment dose for a major depressive disorder, they might be getting hot flushes as a consequence of that medication. So we often need to reduce the dose and maybe add something in. So all of these are commonly available medications, and very low doses are what we use. But we need to make sure we're not using paroxetine or fluoxetine, because they can interact with how your liver metabolizes tamoxifen. So when you're talking to your doctor, make sure all of your doctors know what tablets you're taking, so that they're not accidentally prescribing something that they don't know you're on, and inadvertently causing a drug side effect. With these medications with hot flushes, we would generally aim for 12 to 18 months of treatment, slowly taper them down, and for many women, they're through the eye of the storm of the menopause transition, and we can wean the medications off. So it's not a forever. No medication is forever without question. So they can be modified over time. There are some other medication options as well. So gabapentin, this was a medication originally designed for seizure control. And again, we use it in much lower doses, start at 100 milligrams at night and increase it to tolerance and efficacy. It's particularly good if the hot flushes occur in the first few hours of sleep, where it tends to have most of its benefit. And because it's sedating, it can help you to get to sleep. The downside of it, of course, is that sometimes that sedation continues on during the day. So you do need to take it quite early at night. And weight gain can be one of the side effects. Pregabalin, which is another medication very similar, it's the cousin of gabapentin. The studies that have been done haven't been promising, and the argument is generally that the side effects outweigh the benefits. So even though they're related drugs, they seem to work quite differently in this space. Clonidine is an old-fashioned blood pressure medication that we use for a variety of concerns. So we use it for panic disorders, a bit like we used to use, Valium and benzodiazepines. And so it can really help if your hot flushes are associated with that sense of doom or that feeling of panic that, descends on you before even the sweating starts. The side effects can be postural hypotension. So when you go from sitting to standing, you get a bit dizzy, dry mouth, constipation, sedation. But again, the right dose, so maybe, half a tablet, 50 micrograms, an hour before you go to bed, helps you to get to sleep, gets you through the night with the hot flushes. And then, sometimes if women wake up at 1 o'clock in the morning again, they can take another half a dose to get them through that second half of the evening, and perhaps don't take it during the day, because you might be able to cope with the hot flushes during the day a bit better than the ones at night. Oxybutynin is a medication that was originally developed for overactive bladder. But because it's an anticholinergic, it works on multiple pathways and it works on sweatiness. So if there is a lot of sweatiness with your hot flush, like dripping wet, then oxybutynin, 2.5 milligrams twice daily, can be very helpful. The studies were done at looking at 2.5 milligrams twice daily, but the maximum dose is 5 milligrams 3 times a day. And often I'll use it in women in a sort of combination. They might take 2.5 milligrams in the morning and 5 milligrams at night. It's particularly helpful too if the estrogen deficiency of menopause has meant you've got a bit of overactive bladder and you need to pee all the time. And as well as seeing a pelvic health physiotherapist, the oxybutynin can help you to hold on to your wee so that you haven't got that urge or stress incontinence, help you to sleep through the night and reduce just how sweaty you get. Now, other treatments for vasomotor symptoms that are non-pharmacological. So we know that cognitive behaviour therapy, which is a psychological intervention administered rather by a trained psychologist, doesn't necessarily reduce the frequency of hot flushes, but it does make them less bothersome, so women cope with them better. Cognitive behaviour therapy is about examining how our cognitions influence our behaviours and how they influence our thoughts. And so that can be a very helpful strategy for reducing the distress. We know that hypnotherapy in the right hands is not designed to make you dance like a chicken. It is designed to induce a deep state of relaxation really quickly. So the hypnotic suggestion is to make you very zen very quickly. And so we know that hypnotherapy in the right hands can reduce frequency and severity of hot flushes. Acupuncture, unfortunately, quite disappointing in studies in terms of reduction of hot flushes. And it can be very difficult to find an acupuncturist who's not very keen to also give you a range of medications with multiple ingredients on the label that you don't know what they are, and also have an impact, potentially on your liver and metabolism. So that can be problematic. Relaxation and mindfulness exercises on their own, while they're very useful for your quality of life and well-being, haven't been proven to be helpful for hot flushes per se. Yoga, no clear benefits with respect to vasomotor symptoms, but in terms of flexibility and well-being, it's right up there with, the benefits of exercise, which we know are important. And exercise is increasingly being discussed as the new black. It's the new thing, not so new. It's been discussed for some time about how important it is for our mental health and well-being, and also how important it is in preventing cancer recurrence and helping you to get through the rigors of treatment. And you can see your GP for an exercise care plan, to see an exercise physiologist so that you're exercising safely within the limits of whatever your new bodily capacities are. Navina, I'll just stop and draw breath for a minute.
Yes. We've had a couple of questions come through on the chat, but I'll ask you at the end of the presentation. But in the meantime, like, not everybody can or wants to take pharmaceutical interventions, like you mentioned. And so
Yeah.
are there any complementary therapies that can actually help people that are, have been validated or, the research has supported?
The bottom line, unfortunately, is no. And to demonstrate the point visually, I want to show you, this is my fantastic photo technical skills. This is a photograph of an information sheet from the Australasian Menopause Society, which I mentioned at the end as one of a great place for resources. And as you can see, it color codes recommendations about what is safe to take and what is not safe to take. And evening primrose oil, which, we think is a reasonably sort of inert substance, omega-3 fatty acids. I often recommend it for dry skin, for eczema. It can help with nostalgia. In the setting of breast cancer, there is thought to be a mildly estrogenic effect. So whether the estrogenic effect is from soybeans or evening primrose oil or from an estrogen tablet, it's a no-no. Because if it acts in the body like estrogen, whether it be plant-based or made in a lab, it's a no. And unfortunately, there are huge amounts of money being made by people marketing all sorts of stuff to women because we're a big target audience and we're desperate. We've got symptoms, we want them fixed. So this kind of gives you a bit of an idea. So wild yam, no, you can, just no, unfortunately. Insomnia, I think that this is probably the second biggest problem that I see, and it causes so much distress and is probably the main driver of low libido, actually, because libido is absolutely the sort of luxury item on the Maslow's hierarchy of needs of time, things you've got time and effort for, and if you're tired, it's not going to happen. We maintain that pharmacotherapy, so prescribing, it should not be the sole treatment of insomnia. Cognitive behaviour therapy is the preferred first-line treatment for sleep disturbance, and the evidence base for cognitive behaviour therapy is stronger than for any medications, and we should only use medications in combination with healthy sleep habits and CBT. And I feel like when I read that out and when I read the research, I feel like saying, have you ever sat across the table from a woman who hasn't slept for 3 months and said, oh, go do some CBT? Because seriously, she's going to reach across the table and slap you. We do need to be judicious with our use of medications, and we do need to consider the behavioural strategies and other strategies that we can use. The Calm app, and I don't get any pharmaceutical, I'm not sponsored by the developers of Calm app or anything like that. I've got no disclosures there. There are lots of apps for smartphones basically that you can use that can help you to get back to sleep. And I particularly like the Calm app because it's got meditations, it's got music, it's got people reading you stories. And I guarantee that Matthew McConaughey, with that beautiful Texan drawl that he has, reading you a story at 3 o'clock in the morning with your headphones in, even if you're not sleeping, you're resting. And when you're resting your brain and your body, you can say to yourself, yep, I'm not sleeping, but I'm resting and I'm listening to the lovely Matthew here, and this is good. And so it takes the panic out of not sleeping, because then when you don't sleep, you panic and then the whole thing goes around in a circle. So get some good noise cancelling headphones, particularly if your partner snores like mine does. Right, if you were to take a medication, then you could start with something like melatonin. So 2 milligrams of melatonin. Some people will take 4 milligrams, slow release at least 2 hours before bed. For some people, that works really well. You do need to take it for a while for the effect to become obvious. It's not a sort of short-term fix when we're using it in this setting. Clonidine, again, at slightly higher doses, because the higher the dose, the more sedating it is. Then sometimes we use sedating antidepressants. So amitriptyline, which we use, as I said, we also use it if you've got neuropathic and joint pain. So if you're taking an aromatase inhibitor, for example, and you've got some joint pains as a consequence of that, or neuropathy because of your chemo, then 10 milligrams of Ndep at night, probably 2 or 3 hours before you go to bed, can help you to get to sleep. Mirtazapine, which is another antidepressant, in very low doses, like 7.5, so half a tablet to 15 milligrams, can also be great for getting you to sleep. It can also stimulate your appetite. So if appetite loss and nausea is an issue for you, that can be very helpful. The downside is if it stimulates your appetite and you want to eat pavlova at 3 o'clock in the morning, it's not so good. Don't eat the pavlova at 3 o'clock in the morning. Just walk away. Trazodone and dithiapine are other sedating tricyclic antidepressants, again, in very low doses. At those doses, they're not going to do anything for depression or anxiety. But if you sleep through the night, your emotional continence and your ability to, quite frankly, literally hold your shit together during the day is going to be much improved. The occasional temazepam can be quite useful, and I have a number of women who will use a temazepam for special occasions or emergencies. Say, for example, on Sunday night, the night before, so that they can at least get a decent night's sleep on Sunday night to get themselves through the week, or before a big meeting or an important event where they need to have had a decent night's sleep. The problem with benzodiazepines is that you habituate really quickly, so you get used to them. So they're a special occasion, intermittent dosing, then they're best. Belsomra is a new medication that works on a neuropeptide in your brain called orexin A that's found to be deficient in postmenopausal women. And there's one study that suggests that it might reduce nighttime vasomotor symptoms. It's not on the PBS, so it's a private prescription, so it's $60 a month. And so sometimes that's a decision that you make because your melatonin's on the PBS, clonidines on the PBS, amitriptyline's on the PBS, so is temazepam, but Belsomra is $60 a month. So, you sort of work your way through the list. Zolpidem is another non-benzodiazepine sleeping tablet, varying, degrees of success with that. In reality, you probably only get an extra 45 minutes sleep with it. And some people find that they get some hypnagogic, so as you go to sleep, some hallucinations and some bad dreams. So that can sometimes be problematic. And then quite often by the time people get to me, they're already self-medicating with over-the-counter antihistamines. All of those things, the Phenergan, rest of it, will work for a little while. If you happen to have hay fever, fine, makes good sense, but you can also adjust to those as well. And you do need to make sure you've got a regular routine around going to bed and getting up. So you do become a bit of a nana when it comes time to going to bed, and when it times the getting up, welcome to midlife.
Okay.
Now,
one of my favorite topics, I think, which is dry.
George or vagina?
I know. You're the vagina whisperer, so, here we go. So dry and or itchy and or bleeding vulvas and vaginas. Like, why? God, why? Like, seriously.
Right.
Torturous. Can you help us?
Yes. So the short answer is, and the reason why I always have George for this slide is because sometimes when I give these talks, there's waiting staff in the room and photographers, and I feel like I'm either going to traumatize them or educate them, and I'm not sure which way it's going to go. And when we were in Mission Beach, we were outside at a resort and there were families having dinner, and I was like, oh, okay, no vaginas. And nothing says vagina to me like a photograph of George. It's my talk, so, So the reason why you get atrophic vaginitis and genitourinary syndrome of the menopause is because you need estrogen to be able to hang on to collagen. And if you can't hang on to collagen and you can't hang on to moisture, then you lose elasticity and stretch. But the list of things that can go wrong with your vagina is very long. Keeps me very busy all day sorting out vaginas, and it's like a box of chocolates. I never know what I'm going to get when I get the referral. And it is not okay for someone to say you've just got thrush or you've just got atrophic vaginitis without examining you. If they make a diagnosis without an examination, then politely get up and walk out of the room and go and see another doctor. You must absolutely always be examined, and a swab can be very useful. And if that doctor doesn't know what they're looking at, it's not their area of expertise, and for a lot of people, unfortunately, it's not an area that's well taught or well experienced, then get a referral to either a sexual health physician or a gynecologist or a dermatologist. There are dermatologists who particularly specialise in vulval dermatology. So you can have a whole heap of things go wrong. You can have a bacterial overgrowth condition, and that can happen because the estrogen levels drop. And when estrogen drops, the bacteria in the vagina also change. So it changes the smell as well. So it's not bacterial vaginosis, but it just smells different than it used to, because you lose the lactobacilli, which are the housekeeping bacteria. And so the balance of bacteria gets a little bit thrown out. You're more prone to getting urinary tract infections. You're more prone to getting inflammatory conditions. You're also more prone to, at that stage of life with a drop of estrogen, have issues with some of the autoimmune skin conditions. So skin on your vulva is skin just the same as anywhere else, and you get all sorts of rashes and things. And so the less you put on it, the better. And there are a number of over-the-counter preparations that the list of ingredients makes my skin crawl, and I want to take them all off the shelves. So we're going to talk about what you can use and what you can't use. So don't wash with soap. Don't wash out your vagina. It's not designed to be douched. Even if it's a special douching product, it's not. It's just a marketing strategy. Avoid it. Cotton undies, so things, your vagina down there, it's meant to breathe. The reason why you've got pubic hair is so that the secretions can be whisked away so that the skin is kept protected. So pubic hair needs to come back in fashion. Please, I beg you. G-strings, not a good idea for anyone. They're called G-strings because, gee, that's uncomfortable. Anything perfumed is not meant to go down there. And even botanicals. So even if it's fragrance with lemon scented, or I don't know why you'd want your vagina lemon scented, but even botanicals can cause irritations. There are a number of lubricants and emollients that you can use. So Replens or Refresh. Acid gel is sometimes used. Disappointing results, though, I have to say. I would generally use half the amount that they recommend. Otherwise, you just feel a bit sort of wet and sticky. Lignocaine gel is sometimes advocated. It's a numbing gel. The idea is that you put the numbing gel on your vulva so that you can't feel the burning or the itching, or you can tolerate penetration. The idea of numbing yourself so you can tolerate penetration is something that needs to have gone out in the dark ages. Absolutely not. There's a good silicone and a water-based. They do two versions, and with the unfortunate name of Yes. I don't know why they called it that, but anyway. You can buy it online, and there's, people have a preference of whether or not they want water-based or silicone-based. Olive and Bee, which is an olive oil and beeswax lubricant, which I mentioned coming up, is an absolute gift in this situation. It was designed by an Adelaide pelvic floor physiotherapist. It's designed to be used as a lubricant for intercourse, but it can also be used as an internal emollient. So you get an applicator or an empty syringe and put 0.5 ml of olive and bee into your vagina every night and smear it around the outside, and that will replace some of the moisture, not disturb the pH, and give you some relief from some of the symptoms. It will make a stain on the gusset of your undies. So if your undies look a bit sad after a couple of months, just ditch them, get some new ones. Don't worry about it. Don't wear pads. They're bad. Let your vagina breathe. Vitamin E has also been used in vaginas, research dating back to about 2012. So compounding pharmacies will sometimes make up vitamin E in an ointment base. Make sure it's not perfumed. And there is an American product, it's actually an Italian product distributed by an American company called Reverie, that's a hyaluronic acid vaginal pessary. And the hyaluronic acid vaginal products are very promising. We're literally putting it on our faces every day because it helps to retain moisture. And so that's something to look out for. But also look out for what else they put in their particular products, because some of them have put all sorts of herbal things that are not right. Wine is not the solution. to your vulvovaginal symptoms. So again, if your clinician suggests to you that when you say sex is painful and they say just relax, have a glass of wine, sigh and feel sorry for their partners, because if that's the best that they can do, if that's what they're bringing to foreplay, then you can only feel pity for them and please ask for a referral to see somebody else. Now, this is a resource that I think is really good for heads around. And when you're talking to your clinicians about using vaginal estrogen, you need to know as much as they do, if not more. So the American College of ONG issued a statement initially in 2016 and then in 2020 that summarizes in just 2.5 pages all of the evidence about using vaginal estrogen. And we say, absolutely, non-hormonal approaches are first. So use your Replens, your Refresh, your Reverie, your vitamin E, your hyaluronic acid, your Olivin B. If that's not sufficient, then have a discussion with your medical oncologist about using, or your surgical oncologist about using some vaginal estrogen. There is no data that suggests that there's an increased risk of cancer recurrence for women currently undergoing treatment for breast cancer or those with a personal history of breast cancer who use vaginal estrogen to relieve urogenital symptoms. No evidence of increased risk. You use it slowly, and I generally encourage women to use the Olivin B for 2 weeks first and then add some vaginal estrogen, just 1 or 2 pessaries a week, build it up slowly, and don't go beyond 2 or 3 doses per week. But if you can literally Google that statement, print it off, take the PDF to your clinician, read it, and have that discussion. And it's important for clinicians to understand, and sometimes male clinicians in particular don't understand, that it's not just painful sex. I hate that just painful sex, because clearly they're having very bad sex, and again, we can only feel sorry for them. But it's also about your pelvic floor. It's about urinary continence and being able to cough and sneeze without peeing, and being able to run and jump and do exercise without peeing. So it is important. It is important for your genitourinary health. And to walk around every day being aware that you've got an uncomfortable vagina is a very unpleasant experience. And if it was their testicles, I'm sure they'd have a different opinion. There has also been the emergence of a number of laser technologies. Again, trying to look at extrapolating from cosmetic medicine and in repairing collagen. This is the reason why Jennifer Aniston and all of those people look so amazingly good, is because they've had bucket loads of this laser. The evidence for it has, however, in gynecology been quite disappointing. So the original studies were funded by people who made and sold the machines, so that's a bit problematic. But the research since has shown that while there's a histological improvement in what the cells look like when you take a sample and look at it down a microscope, it hasn't translated into a functional improvement. So technically, your vulva is better because it looks better under a microscope, but it doesn't make sex any more comfortable. Whether or not it can help to reduce the systemic absorption of vaginal estrogen is a study that has not yet been done. And I suspect from my read of the literature that that's the potential. However, this is not a treatment it's not FDA approved, it's not TGA approved, and depending on who you go and see, it's $500 to $800 per treatment. You need to have 3 treatments. The first ones can be a bit painful, and then you need to continue to have treatments every year. So really, this should be still being done in a research setting. You shouldn't have to pay for this. But you make your own decision about whether or not you think that that's something that you wish to pursue. But be mindful that the person who's offering you the treatment has spent $250,000 on the machine and they want to recoup their money. Just saying. This was a paper that was published in 2018 in the Journal of Endocrinology, looking at using vaginal testosterone to relieve urogenital symptoms, because we know that the vagina has testosterone receptors. And in the US, you can actually get some DHEA, so testosterone precursor creams to use for vulvovaginal atrophy, because the testosterone is then aromatase to estrogen. That's what our ovaries do. In fact, our ovaries make testosterone first and then they convert it to estrogen. So technically we have more testosterone than estrogen. And the research around this was actually really promising. And the difficulty was that they studied women for 24 weeks, 44 women with a very small amount of testosterone, and the results were quite encouraging. And they said the usual thing that we always say at the end of research papers: warrants further investigation and studies of longer duration. And for some reason, that hasn't yet been done. When I spoke to Michelle White about it, she didn't know why. I suspect it's around funding issues, but this is a paper that you can access off PubMed, read for yourself. It's got the recipe in there, and you can take that to your doctor and say, I would like to try this testosterone cream. Please write me a prescription for the compounding pharmacy because I want to give this a try. It's all there. Another thing about managing sexual concerns and bladder concerns is the very underused resource of pelvic health physiotherapy in this space. So a women's health physiotherapist, and by that I mean someone who's actually got a master's degree in women's health physiotherapy, not someone who's just a woman and has a vagina herself and therefore is interested in women's health. That's not a qualification. You actually need to have done a master's to be able to do this. We know that women's health physiotherapists, properly qualified, using vaginal trainers or dilators and a good olivin B-based lubricant, can help to decrease the pain, anxiety, and difficulties with tolerating penetration. So it's a hugely underused resource, and particularly for women who've had pelvic radiotherapy, this is a number one thing. And you can get your GP to write an enhanced primary care plan for you to go and see a physiotherapist to help you with this sort of treatment. Because you've got a chronic condition related to your treatment. So you're eligible for some Medicare funding for that.
Wow.
Emotional well-being.
Yeah. Sorry, one of the things that surprised me was about that you can see dermatologists for your vulva. But anyway, that was fascinating.
Yeah. And there's a big group of us, and there's an organisation called the International Society for the Study of Vulvovaginal Disease. Oh. And we were all on a plane at a conference a couple of years ago. And I don't know how the airline knew, but they said, oh, you're all here for the Volvo conference. No, not Volvo, vulva, darling.
No, we're not there for cars, not sweetie cars.
No,
So why does menopause get us feeling down? Is it psychological or is there a hormonal reason?
Well, it's both, really. As we talked about the other night, it's around that change of life. So what does this mean, this cessation of periods? And for some women, it means, that their fertility, any plans that they had for their fertility have been completely scuppered. And it does represent a big change. You might have had thoughts or beliefs or hopes about your future that have now been impacted on by your diagnosis of breast cancer and menopause. So there's that double whammy. And then we know that estrogen in itself is a potent neuromodulator. There's a professor in Melbourne called Professor Jayanthi Kulkarni, and I always mispronounce her name. And she's a psychiatrist, a bit of a guru, who has done a lot of work about how estrogen and estrogen fluctuations affects our mental well-being. So PMDD, premenstrual dysphoric disorder, PMS, postnatal depression, menopause, all of these things. For some women, their first experience of depression and anxiety is actually in the menopause transition. And it's not just related to life events and being busy and overworked. It's about estrogen. But what I wanted to mention here is the difference between being depressed and being demoralized. And it can be hard to tell the difference between the two. And it's important to understand the distinction because it helps us to know how to intervene. If you're depressed, then you might feel isolated. You can't be reassured. You're not sleeping. Your appetite is poor. You've got lack of energy. But the key features that doctors look for or psychologists look for is the presence of either guilt or anhedonia. And so by that, we mean feeling guilty about things. Oh, it's my fault. It's my fault that the family's under stress because I've got breast cancer. And I feel so guilty because I'm not looking after my husband and I'm not present for my kids and I feel guilty, I'm not good enough. If those are your cognitions, if they're the thoughts running through your head and you are feeling guilty, then it might be that you're depressed. If you are cyclodonia, which is the absence of joy, just the feeling that there is, the things that you would normally enjoy, you don't get any pleasure out of. You might have been a mad keen knitter before all this happened and you're like, not interested. The things that usually you did for fun, you're not interested. So that combination of guilty feelings, lack of joy, that is depression, and that warrants therapy and perhaps also medication. Again, 12 to 18 months, get you out of the hole, get your brain back to functioning normally. Demoralized is a feeling common to all of us, and particularly for women facing the onslaught of treatment, is that you feel like, God, I can't do this. I can't do this. It's too much. I'm not going to be able to do it. And I think that it's really beholden upon us to listen, because, you probably have all had this experience that everyone's trying to fix your problems. You tell them how they feel and they treat you. They just need to listen. But one of the things that you can do for yourself is when you're feeling that demoralization is write down a list of all the achievements you've managed over your lifetime, no matter how big or how small. And you'll see actually that list is quite long. So, when people say to you, oh, you've got this, you'll be fine. Well, actually you do got this because you've got form. You've actually got the lived experience of previously being able to manage and being able to achieve and get through things that are incredibly difficult that some people would absolutely balk at. Take pleasure in small things. Buy clothes that fit. This is around body image. If your clothes don't fit you anymore because your body shape has changed, then get some new clothes. Just do it. You don't have to spend a lot of money. You don't have to buy a lot of stuff. But there's nothing more depressing than trying on clothes every morning that don't fit you, that make you look like you don't want to look anymore. Put them in a bag, donate them to someone else who can use them before they go out of fashion, and go get yourself some new stuff. Paint your toenails, paint your fingernails, make yourself look good. Work with what you've got. We've all been doing that for a long time. It's no different. Find friends that get you. And if there are people in your life who are not helpful, cut them loose. I think one of the things that happens with these big transitions in life is you work out how many F's you've got left to give. And when you've at this stage of life, you've probably run out of them. It's a good time now to just cut those people free. Engage in random acts of kindness. Buy the big issue, compliment someone, say thank you. It's amazing how much better those little things can make you feel. And then if that fails, watch some Celeste Barber just doing her thing, taking the mickey and making us all feel like actually really normal women. Thank you, Celeste.
Oh, I love Celeste. She's
she's great, isn't
so
she?
good for us. So cancer and menopause separately, but together, they're an actual, a bomb of a thing that happens to people and can have such a detrimental impact on people's relationships. How do we keep the intimacy home fires burning?
Yep. Well, there's a lot to answer with that, and I hope that I can try and address it. It's interesting that for some people, when they're first diagnosed, that physical intimacy is even more important to them. It's, it can be how they connect. It can be how they feel alive. It's how they feel loved and validated and seen. But for some people, it's like, don't touch me. I've handed over my body, lock, stock, and two smoking barrels to the radiologist. Everyone comes to touch you, to do things to you. And you feel like you're on this kind of conveyor belt of scanning and bloods and gel codes. And every time I have to have a drip put in or a gel code or a blood taken, I say a little prayer to apologise for every time I did that to a patient when I was an intern. And so it's so important for you to have ownership and agency of your own body to have a good libido. I think that's the number one thing, and feeling safe. And that can take a bit of a beating, when you're going through treatment. The problem is that when libido diminishes, we panic because we think that that means that love is diminishing. And that's not necessarily the case, which is why it's so important to keep talking about what's happening with libido and how you still are experiencing love and how you still want to experience intimacy, because intimacy is not just about penis, vagina, sex. I mean, let's, think a little bit more broadly here. It's not just limited to that. And it's the difficulty with libido, even in all long-term relationships, cancer, no cancer, kids, no kids, is that it's not just about time, because it doesn't actually take that long. It's about the emotional space. So whatever you can do to remind you of the woman that you were before you had breast cancer, to connect with who you are as a person, not just as a woman living with breast cancer, that will help you to build your agency and help you to reconnect with your libido. Testosterone is gone, estrogen is gone, and so you're not going to have that urge in that sort of biological drive. You're going to have to harness your emotional libido. And if you get the opportunity to listen to Esther Perel's excellent TED Talks, she is just amazing. She's who I want to be when I grow up. She's a psychologist. And she talks even quicker than I do. But she's amazing in this space. And she's got a 20-minute TED Talk called Maintaining Desire in Long-Term Relationships that should be compulsory viewing for anyone who's trying to stay together. Talking about sex is often the elephant in the room, and there's good evidence to tell us that patients want the doctors to bring it up, and the doctors don't want to bring it up because actually they don't really know the answer to the question. And as doctors, we get really freaked out if we get asked questions that we don't know the answer to, so we sort of obfuscate a bit. Find someone that you can talk to, ask for a referral. Because even though we are supposedly open and liberated about sex in Australia, I don't think we are. We make jokes and we diminish and we hope things will magically get sorted out and our partners will magically just kind of read our minds and know how we're feeling. And you know what? That anyone who's been in a relationship for longer than 10 minutes successfully knows that doesn't work. Going behind the bathroom door and sulking and hoping that he's going to read your mind and know what you're going to have to use your words. A bit like talking to kids. You actually have to explain things and let people know. All right, we're running out of time because I'm talking too much. Sex therapy is rarely about gymnastics of sex. It's about relationships and communication. And a good emotional IQ is more useful than any lubricant. We shouldn't panic when sex goes bad. We need to just actually think about what it means and where the relationship is. And I really want to get through this little bit. The 5 Love Languages is an excellent little book written about how we express love and affection. And the central thesis is that we have different ways of showing our love and regard. And we express our love and regard in the way that we would also like to receive it. So, for example, if gifts say to you, absolutely, I feel loved, then you're going to give gifts. But if the person you're giving the gift to, if their number one love language is quality time, you can buy them as much stuff as you want. It's not going to work. You're talking at cross purposes. So a little exercise I like to do, a sex therapy exercise I like to do with couples is work out your top 5 in order of priority. Try and guess your partner's top 5. See if you got it right. Swap notes. Do it, over dinner while you're having a glass of wine. If you didn't get it right, talk about it and think about it before cancer, after cancer, before kids, after kids, other big life events, because in the natural life of a couple, if you're going to stay together and stay resilient, it's going to change. The sensate focus is another technique. You can Google it, look it up, and there are descriptions about how to reintroduce. It's a sort of, if you'd never had sex before and you were learning and you wanted to do a different dance, then this would be how you would do it.
Okay,
there's some fantastic results.
Yeah, so we have 5 minutes and I've got 3 questions. One is about resources.
Okay.
So
Yep.
Are there any other resources that our attendees can access?
Yes. So the Australasian Menopause Society's got fantastic information sheets and videos in lots of different languages on every single topic about menopause you could possibly think of. This book is a book written by an OT who had her own experience of breast cancer and wrote about how to talk to her partner, how to talk to her doctors, and how to actually use your words to say, I'm not feeling okay about this right now, and this is what I would like to do. It's a little book, easy to read, very, very useful. Buy it over Amazon, because I think she's self-published. Charlotte Totman, I'm in awe of this woman. She's brilliant. I hate it when I have to give a talk after her because I always feel like a nincompoop. She's so elegant and erudite and brilliant to listen to. And you can get your partner to listen and your kids to listen to these as well, because hearing this stuff out loud from someone else's voice validates your concerns. Kaz Cook, anything she writes is brilliant. This book about menopause is great. And then most of the evidence that I used to discuss the medications in the talk this evening were drawn from this document. And so the document for doctors is 181 pages long. You can read it if you like. It'll certainly sort out your insomnia. But there's a 28-page version for consumers that sorts through the evidence about which is best and why. And so you can read that yourself and just download it from the magical interweb. And then I'll stop.
Cool. Thanks, Tonia.
Sorry, there's so much to cover.
I know. And you know what? An amazing treasure trove of information you provided us with so far. We've had so many questions come through, but we've only got time, and I'm going to ask two really short ones, hopefully. After which, for the attendees, if you can hang on for 5 more minutes, I'll close out the session with some information. Tonia, do you take, it says, does Dr. Mezzini have her books open for telehealth sessions for regional Victorian patients?
It's always better if I can see people face to face, because if you need to be examined, it's problematic. And I can't always work out who needs to be examined and who doesn't. So telehealth doesn't allow me to do that. So if you've got a good gynecologist or someone I can collaborate with, and that's clear in the referral, then absolutely, you know, we can work it out that way. But somebody who knows what they're looking at needs to be able to examine you and to be able to collaborate with me and not get offended if I suggest something that, you know, they're not used to. I'm thinking about.
Maybe we need a Doctors of Vulvovaginal Club of Australia.
There is. If you look, yes, you look at the Australian and New Zealand Vulvovaginal Society, so ANZVS, and they've got a list of all their members. So they're all the people that pay their money, go to the courses, do the extra study. And you can also go onto the Australasian Menopause website, and there's a list of all the doctors that do menopause. It's not necessarily an endorsement, but you know, you're going to put yourself up there if you've got an interest and you've done some extra study and training. So that's how you can find people close to you.
Thank you. And there's one, again, hopefully quick one. Do I need to watch for soy in ingredients if it mimics estrogen?
Yes. Yes, because it mimics estrogen.
Yeah. Thank you.
Yeah.
Well, thank you so much, Tonia. For the attendees, I just wanted to take you through a few things. There's a bunch of upcoming events and BCNA resources. The BCNA newsletter, which is called The Beacon, the October edition is out, but the next edition is due in April next year. So please keep an eye open for that. BCNA will be running a webcast on persistent pain after early breast cancer treatment on the 7th of February next year. So please sign up for that if it's of interest. BCNA, again, will be running an information forum in Murray Bridge, South Australia on the 6th of March. So if you're nearby, please feel free to go along. They're often got people like Tonia who go along to those and present along with the members of BCNA, the staff members of BCNA, for you to have conversations with, to raise issues that we need to do stuff about. There's podcasts from Dr. Charlotte Totman, who Tonia mentioned, as well as a new BCNA website on which you'll find all the digital resources, including webcasts, virtual conferences, and the other podcasts. The link to this webcast will be uploaded soon. there is a tool that BCNA has called My Journey, which has all the up to date and I guess cross-checked breast cancer information for your diagnosis in one place. Latest information about DCIS, early and metastatic breast cancer, which is tailored for your situation. And you can access it through your web browser at www.myjourney.org.au. Oops, sorry, I clicked ahead. Fat fingers, we can blame them. Please take care of yourself. Tonight's webcast might have raised some distressing feelings for you. There are a few options you can reach out to. One is the BCNA hotline on 1-800-500-258. You can speak to a member of your treating team or your GP. You can call your local cancer council on 13 11 20 to speak to a cancer nurse. And if you're experiencing a higher level of distress, there's support available 24/7 through Beyond Blue or Lifeline. And the numbers are noted on the slide there. Now going backwards. Always happens. I'd like to close out by first thanking Tonia Mezzini so very much. I have learned so many things listening to you and speaking to you the other night, and I think there should be an entire series, but I'll try and tackle that. Yes, I'll try to tackle that. Let's see. Watch the space, attendees. Maybe. I mentioned already that the link to this recording will be available on the website soon. This Ask the Expert digital event received funding from the Australian government, so we thank them very much for supporting us with breast cancer and other illnesses. And there is a link to the post-event evaluation survey and the handouts tab of this webcast. This survey helps us develop our content that's relevant to our audience. So please take the time to fill it out, because then it'll help us, help guide us in future webcasts. Thank you very much and have a good evening.